Imagine a cancer so aggressive that it literally turns your stomach into a rigid, non-functioning leather bottle.
Yeah, and then imagine a completely different type of cancer in that exact same organ, but, one that doctors can cure completely using nothing more than a standard 14-day round of basic antibiotics.
It's wild. It completely defies how we normally think about human anatomy and disease. So, welcome to the deep dive.
Glad to be here.
Today we are taking you on a tour of an organ you probably, well, you only really think about when you are starving or maybe when you've eaten way too much at Thanksgiving.
Right, the stomach.
Exactly. We have a huge stack of sources here, specifically this highly technical, comprehensive, clinical, and surgical guide to the stomach. And our mission today is to translate this honestly very dense medical textbook into an awe-inspiring tour of your own body.
We are going to extract the most fascinating quirks, the mechanical failures, and the profound medical mysteries that are happening just below your ribs.
So to really understand how this organ goes wrong, we first have to look into how it is built,
Yeah.
right? And that story starts way early.
Oh, very early. In the fourth week of embryology, actually, when you are just a tiny developing embryo, your digestive tract is basically this straight, simple tube called the foregut.
Just a straight pipe?
Exactly. But it does not stay that way. The developing stomach performs this incredibly complex gymnastic routine. It executes a 90-degree rotation along two different axes simultaneously.
Wait, two axes at once?
Yeah, it physically rings itself into position right in the middle of your abdomen.
And I guess when a physical tube twists 90 degrees inside a developing embryo, everything attached to it just has to get dragged along for the ride.
Which is exactly why surgeons have to memorize this event. They use this mnemonic called LRP. It stands for left becomes anterior, right becomes posterior.
Okay, LRP, left anterior, right posterior.
Right. So the vagus nerve, which acts as the main communication cable from the brain to the gut, it originally runs straight down the left and right sides of that embryonic tube.
Got it.
But because of that 90-degree spin, the left vagus nerve gets dragged all the way to the front, the anterior of the fully formed stomach, and the right nerve gets dragged to the back.
So your stomach is essentially like a twisted balloon animal that settled into place and dragged its own electrical wiring with it.
That is a perfect way to put it.
And once it is fully grown,
Yeah.
looking at the specs in this guy, this thing is an absolute beast. It notes it has a capacity of about 1.5 liters.
Yeah, it can hold a lot.
But here is what gets really interesting for me. Most of your digestive tract has two layers of muscle, just to, squeeze food downward in a wave. But the stomach has three.
3 distinct layers, yeah.
It features this innermost oblique muscle layer that is completely unique to this specific organ.
And that oblique layer runs diagonally across the organ. Because of that specific angle, the stomach doesn't just push food along, it actively wrings itself out like a wet towel, just grinding and pulverizing whatever you just ate.
It is essentially a custom-built biological concrete mixer. A concrete mixer with a secret extra gear just to smash up the slice of pizza you didn't chew properly.
Right, it does the heavy lifting.
But looking through these surgical notes, there is this one piece of anatomy that sounds like a comic book supervillain. The guide warns surgeons about the criminal nerve of Grassi.
Oh yes, the criminal nerve.
I am assuming it's called criminal because it manages to pull off some sort of surgical heist.
It absolutely sabotages the entire operation. So that vagus nerve we mentioned earlier, the one that rotated to the front and back, it branches out extensively to control the stomach's acid production.
Right.
One of these tiny, really easily missed branches hiding on the posterior side, so the back of the stomach, is the nerve of Grassi.
And why is it such a problem?
Well, historically, when patients had severe, life-threatening stomach ulcers, surgeons would physically cut the vagus nerve. That was the treatment to stop the stomach from producing so much acid.
But because of that weird embryological spin, the anatomy in the back is messy. So they would miss this one specific tiny branch.
Exactly. They would close the patient up thinking the acid factory was completely shut down. But that single, untouched criminal nerve would just keep happily firing signals, pumping out massive amounts of acid.
Oh, wow. So the patient goes through this major abdominal surgery only to have their severe ulcers return almost immediately.
Yep. It earned its moniker because it is this hidden culprit that fundamentally ruins all of the surgeon's hard work.
Which is just terrifying. Having a heavily muscled, intricately wired concrete mixer is a biological marvel. Unless, of course, the cement you are mixing is a highly corrosive acid capable of literally dissolving the mixer itself.
Which brings us to the delicate chemical balance of the stomach.
Right. Acid secretion.
Yeah, acid secretion is highly orchestrated, and it happens in these distinct phases. The cephalic phase accounts for about 30% of your acid, and it is triggered entirely by your brain.
So just thinking about a burger.
Just the sight, smell, or even the thought of food prompts the vagus nerve to tell the stomach to start preheating the oven, so to speak.
That is crazy.
Then there is the gastric phase. When food actually lands in the stomach and physically stretches those muscle walls, the stomach responds by producing 60% of the required acid.
And then there's a final phase.
Yeah, finally, there is a small intestinal phase as the food moves on.
And when that highly orchestrated balance fails, we get peptic ulcer disease. The acid just starts eating into the tissue.
Which is incredibly painful.
Now, the source material draws a really sharp, almost counterintuitive distinction between the two main types of ulcers. You have duodenal ulcers, which occur just past the stomach in the upper intestine, and gastric ulcers, which happen inside the stomach itself.
And the clinical deduction here relies entirely on the mechanics of eating. It is fascinating. If a patient has a duodenal ulcer, they typically complain of hunger pain.
Hunger pain. So it actively hurts when their stomach is empty.
Exactly, because when the stomach is empty, acidic fluid just drips freely through the exit valve and washes right over that raw ulcer in the duodenum. But when the patient eats a meal, the stomach tightly clamps that exit valve shut so those oblique muscles can churn the food.
So eating physically blocks the acid from reaching the duodenum, giving the ulcer a temporary break.
Right, they might even wake up in the middle of the night in total agony just because the stomach is empty again.
Wow. But contrast that mechanical reality with a gastric ulcer, which is located inside the stomach walls.
That is a totally different story. If you have a gastric ulcer, eating food is the worst thing you can possibly do.
Because of the stretching.
Yes. The physical stretching of the stomach walls literally pulls the raw wound apart, and then that massive flood of new acid produced during the gastric phase immediately burns the exposed tissue.
Because the act of eating causes instant agony, the guide says these patients often develop an aversion to food and experience really severe weight loss.
Yeah, they literally become afraid to eat.
And whether gastric or duodenal, these ulcers can bleed. The text has this incredibly vivid grading system called the Forrest classification. Gastroenterologists use it when they look at an ulcer through an endoscope.
It's a vital tool.
But it's not just for documentation,
Yeah.
right? It dictates exactly what the doctor does next.
Absolutely. Every grade demands a different protocol.
Yeah.
At the mild end, you have a Forrest III, which is an ulcer with a clean, healing base. You can safely send that patient home with just some medication.
Okay, but what about the other end?
At the catastrophic end of the scale, you have Forrest IA, which the medical text literally categorizes as spurting.
Spurting. That is just a terrifying word to encounter in a medical context.
It means a major artery has been breached and blood is actively pumping into the stomach cavity. That patient is not going home. They need immediate life-saving intervention.
And what fascinated me most about these ulcers is that they aren't just caused by, like, NSAA painkillers or bad diets. Physiological stress can literally eat holes in your stomach.
Oh, absolutely.
And I don't mean the stress of missing a deadline at work. The guide details two bizarre triggers: curling ulcers and Cushing ulcers.
Right, so a curling ulcer occurs in patients who have suffered severe, extensive body burns.
Burns on the skin.
Yes. When a huge percentage of the skin is burned, the body loses massive amounts of fluid, causing overall blood volume to just plummet.
Hypovolemia, so the blood pressure drops.
Precisely. And when blood pressure drops, the body has to prioritize sending blood to the brain and the heart. The stomach is deemed non-essential, so its blood supply is drastically reduced.
Oh, wow.
And without a robust blood flow, the stomach cannot produce the thick, protective layer of mucus that normally coats its inner walls. So the baseline acid just eats right through the suddenly defenseless tissue.
So a burn on the outside of your body indirectly causes a chemical burn on the inside of your stomach. That is wild. What about Cushing ulcers?
Cushing ulcers are entirely neurological. They are caused by severe head trauma.
Head trauma causing stomach ulcers.
Yes. If a patient suffers a traumatic brain injury, the brain swells inside the skull. That intense intracranial pressure pushes down on the brainstem, which sends the vagus nerve into a state of absolute overdrive.
So the brain is essentially screaming at the stomach.
Exactly, skyrocketing acid production to lethal levels until the organ essentially dissolves itself.
You get hit in the head and your stomach short circuits.
Yeah.
But even that is not the most extreme acid situation in the source text. There is a condition called Zollinger-Ellison syndrome.
Oh, Zollinger-Ellison. It operates on a completely different mechanical level.
Gosh, so.
Well, a patient develops a tumor, usually located in a specific anatomical region between the duodenum and pancreas, known as the Passaro-gastronoma triangle.
Okay.
This tumor is basically a rogue, unregulated factory. It produces massive, continuous amounts of a hormone called gastrin.
And gastrin is the chemical messenger that tells the stomach to manufacture acid.
Exactly. In a normal, healthy person who is fasting, gastrin levels are incredibly low. But in a patient with Zollinger-Ellison, those levels are routinely over 1,000.
1,000.
Yeah, their stomach is perpetually flooded with industrial volumes of acid, resulting in multiple atypical ulcers that simply will not heal with normal antacid medications.
So we have an organ wired directly to the brain, vulnerable to blood volume drops from burns, and at the mercy of rogue hormone tumors.
It is sensitive.
But the most famous villain in this clinical guide isn't a tumor or a traumatic brain injury. It is a bug, H. pylori.
H. pylori is a spiral-shaped gram-negative bacterium, and for decades the medical establishment absolutely refused to believe a bacteria could survive the harsh, highly acidic environment of the stomach.
Because it's basically a vat of acid.
Right. But its gram-negative status means it has a robust double-cell membrane, making it exceptionally tough. But more importantly, it secretes an enzyme called urease.
Which the guide says acts like a neutralizing force field.
It does. It converts urea into ammonia, creating a localized alkaline bubble around the bacteria. It basically builds its own chemical spacesuit to survive the acids.
A spacesuit. I love that.
Yeah, and this allows it to burrow into the stomach lining and cause chronic smoldering inflammation.
And chronic inflammation leads to some dark places. This is the part of the source material that genuinely made my jaw drop. The guide directly connects H. pylori to a specific type of cancer called multiple lymphoma.
Yes.
We touched on this at the very beginning. The stomach isn't just a vat of acid. It's a reactive ecosystem.
And it is one of the greatest triumphs of modern gastroenterology. See, the stomach is the most common site in the entire human body for extranodal lymphoma that originates outside the lymph nodes.
Okay.
Multiple lymphoma is a tumor driven almost entirely by the immune system constantly fighting and failing to clear out that H. pylori infection. The constant state of war causes the immune cells to literally mutate into cancer.
But the treatment is what's truly mind-bending. The guide explicitly states that for early-stage multiple lymphoma, the standard of care is not chemotherapy. It's not cutting the stomach out.
No. The standard of care is a 14-day triple therapy. It consists of a heavy dose of regular antibiotics and acid reducers aimed solely at killing the H. pylori bacteria.
Just killing the bug.
Yeah, if you eradicate the bug, you remove the source of the inflammation. In 70 to 80% of early-stage cases, removing the bacteria causes the cancer to simply regress and disappear.
Curing a malignant cancer with a course of antibiotics.
It is amazing.
It is a phenomenal reminder that diseases don't exist in a vacuum, They rely on environmental triggers.
Absolutely.
But if that chronic inflammation goes on long enough, it creates scar tissue. And thick scar tissue leads us out of chemical failures and straight into mechanical plumbing disasters.
Plumbing failures in the digestive tract are incredibly dramatic, and they can start just weeks after birth.
Yeah, the text details a condition called infantile hypertrophic pyloric stenosis, or IHPS. It typically affects infants, mostly firstborn males, right around 3 to 6 weeks of age.
Right. And if the pylorus is the muscular valve at the exit of the stomach, hypertrophic means that muscle is growing out of control. It is literally over-engineering itself.
So it grows so thick and rigid that it completely blocks the exit.
Exactly. The stomach is trapping its own contents. Pediatricians can actually palpate or feel this overgrown muscle right through the baby's abdominal wall.
Wow.
It is universally known as the olive sign because it feels exactly like a small, hard olive sitting right under the skin.
So the stomach is full of milk, the exit is blocked by this olive-like muscle, and our concrete mixer just keeps squeezing and churning harder and harder to push the food out.
But it's hitting a brick wall. The pressure has nowhere to go but backward.
Which results in the hallmark symptom, non-bilious projectile vomiting. The stomach forcibly and violently ejects the milk back up the esophagus.
And the distinction of it being non-bilious is the crucial clinical clue, right?
Right, because bile is introduced in the intestines. Because the blockage is at the stomach exit, the milk never actually reaches the intestines, so there is no green bile in the vomit. It is pure, undigested stomach contents.
It is a perfect piece of mechanical logic. And curing it requires a highly specific surgery called a Ramstedt pyloromyotomy, where the surgeon delicately slices lengthwise through that overgrown muscle to release the tension and open the valve.
It's just a mechanical fix.
Mm.
But adults have plumbing disasters too. The guide outlines something called gastric volvulus, which honestly sounds like an ancient Roman curse.
It does sound like one, but it is actually a terrifying mechanical failure.
What happens?
Gastric volvulus is when the stomach literally twists in on itself. It can flip upside down along its short axis or roll along its long axis.
Like twisting a balloon.
Yeah, and when the organ twists, it pinches itself closed at both the entry and the exit, creating a totally closed loop. Worse, the twisting action can strangle the blood vessels supplying the stomach, leading to tissue death.
The source mentions doctors diagnose this using the Borchardt triad. It's 3 simultaneous symptoms: severe upper abdominal pain, the total inability to pass a medical tube down the throat into the stomach, and violent retching without actually vomiting anything up.
The retching without vomiting makes perfect sense when you think about it.
Right, the brain is triggering the vomit reflex, but because the stomach is twisted shut at the top like a balloon animal, nothing can physically escape.
It is a completely sealed off system.
But if we're discussing blockages, we really have to talk about the physical obstructions that accumulate inside the stomach over time. Bisors.
Bisors. A mass of completely undigested material.
The textbook lists a few varieties. Phytobisors, which are giant, dense clumps of indigestible vegetable fibers. Trichobisors, which are massive human hairballs.
Yeah, and the clinical guide notes that if a hairball gets so enormous that it forms a literal tail extending out of the stomach through the pylorus and down into the small intestine, it is medically diagnosed as Rapunzel syndrome.
Rapunzel syndrome, a strangely poetic name for a grim physical obstruction.
Highly descriptive, though.
True. But the third type, pharmacobisors, fascinated me. These are massive, cemented clumps of undigested pills and medication capsules. What is wild is the prescribed treatment here.
Oh, the cola treatment?
Yes. The clinical guide clearly states that before rushing to surgery, doctors will treat pharmacobisors or phytobisors with cola. They are literally pouring soda down the throat to unclog the plumbing.
I mean, it sounds absurd, but it's pure chemistry. Cola contains high levels of phosphoric acid and has a very low pH, combined with active carbonation bubbles.
Okay.
So if a patient has a massive plant or pill bisor, doctors will have them drink Coca-Cola, or they will snake an endoscope down and spray the cola directly onto the mass.
That is insane.
The phosphoric acid and the mechanical action of the carbonation enzymatically dissolve the fibers and the pill casings.
It is brilliant. For a twisting volvulus, you need emergency surgery. For medication blockage, you just need the Enzac breakdown power of a soft drink.
Exactly. And sometimes the plumbing issues aren't blockages at all, but bizarre vascular anomalies that just spring a leak.
Like gaving E.
Right, gastric antral vascular ectasia. The internal blood vessels dilate and engorge in these bright red longitudinal stripes along the stomach wall. It makes the inside of the organ look exactly like a watermelon.
And then there is Dieulafoy's lesion. Normally, major arteries run deep beneath the stomach wall, but in a Dieulafoy's lesion, an abnormally large aberrant artery runs just millimeters beneath the fragile surface lining.
And because it is so dangerously close to the surface, the slightest chemical erosion or mechanical scrape can rupture it.
Causing a massive, completely painless, and terrifying internal hemorrhage.
Yeah. So we've covered the chemical burns and the physical blockages. Now we must turn to the darker side of this organ.
Right. What happens when the cells themselves mutate?
The narrative of gastric cancer in this textbook reveals an incredibly complex, albeit tragic, mapping of human anatomy.
The text uses a Loren classification to divide gastric cancers into 2 primary types, intestinal and diffuse. The intestinal type forms distinct gland-like tumor structures, largely driven by environmental factors like diet or chronic H. pylori infections. But the diffuse type is a completely different beast.
Diffuse gastric cancer is poorly differentiated. The mutated cells, they don't bother clumping together to form a neat, identifiable lump.
Oh, so how do they spread?
Instead, single cancer cells aggressively infiltrate and scatter throughout the entire muscular wall of the stomach. They specifically invade those 3 muscle layers we discussed at the beginning, replacing the flexible muscle fibers with stiff, dense scar tissue.
This brings us back to the hook. The source describes the end stage of this diffuse spread as linitis plastica. The stomach entirely loses its elasticity. It cannot stretch to accommodate food. It literally turns into a rigid, non-functioning leather bottle.
And this diffuse type has a terrifying genetic driver.
The CDH1 gene.
Yes. The guide highlights a specific mutation in the CDH1 gene, which causes a condition called hereditary diffuse gastric cancer, or HDGC.
And the risk with that is huge, right?
Astonishingly high. The CDH1 mutation carries a lifetime risk of stomach cancer up to 70% in men and 56% in women.
Wow.
And because diffuse cancer doesn't form a visible lump, standard endoscopic surveillance is effectively useless. The cells are hiding inside the walls.
Wait, I need to stop you here. You established earlier that the stomach has a unique oblique muscle. It secretes intrinsic factor to absorb vitamins, and it creates a highly specific chemical cocktail to break down fluids. Yet the textbook recommendation for someone with this genetic mutation is a prophylactic total gastrectomy between the ages of 18 and 40. They literally cut out the entire organ before cancer can even form.
They do.
How do you just rip out the concrete mixer and connect the esophagus directly to the intestines? Wouldn't the patient starve, or wouldn't the raw intestinal tissue just get destroyed?
It is one of the most radical physiological adjustments in medicine, honestly. But the human body is relentlessly adaptable. Surgeons perform a reconstruction called a Roux-en-Y esophagogynostomy. They pull a loop of the small intestine up into the chest cavity and sew it directly to the esophagus.
But the intestines aren't built to hold a 1.5-liter meal.
No, they aren't. Patients who undergo this must completely alter their relationship with food. They have to eat very small, frequent meals throughout the day.
That makes sense.
Furthermore, because they have lost the stomach's unique ability to produce intrinsic factor, which is a protein required to absorb vitamin B12, they require lifelong vitamin injections or high-dose supplements to prevent severe neurological damage and anemia.
It's a heavy price, but it obviously saves their life.
It does.
Historically, before we had genetic testing or advanced CT scans, doctors couldn't see these hiding cancer cells. They had to track the spread of stomach cancer entirely by touch.
That is a fascinating part of medical history.
Yeah, this source text dedicates a significant section to the eponyms of spread nodes, named after the observant historical physicians who mapped out the stomach's lymphatic pathways.
Gastric cancer spreads along very predictable highways. If a doctor feels a hard, enlarged lymph node resting directly on the patient's left collarbone, that is, Virchow's node, also known as the Troisier sign,
And why the collarbone?
the stomach's lymphatic fluid drains upward into the thoracic duct, which empties right at that left collarbone.
So a lump in the neck is actually an alarm bell for a cancer in the abdomen.
Exactly. And an enlarged node in the left armpit is the Irish node.
Okay.
If the cancer cells drop down through the abdominal cavity and implant themselves onto the ovaries, it creates a Krukenberg tumor.
Wow.
But the most fascinating pathway leads to the belly button. A hard nodule right in the patient's umbilicus is called the Sister Mary Joseph nodule, named after the surgical assistant who first noticed the pattern.
How does stomach cancer travel to the belly button?
It travels along the embryological remnants of the umbilical cord. Yeah, the falciform ligament connects the liver and stomach region directly to the umbilicus. The cancer cells essentially use the ghost of the patient's umbilical cord as a highway to the surface of the skin.
It's a grim map, but an incredible testament to early clinical observation. Before we leave oncology, there is one more tumor type that completely breaks all the rules. GEST, or gastrointestinal stromal tumor.
GESTs do not originate from the inner lining of the stomach like regular carcinomas. They originate deep within the tissue, from the interstitial cells of Cashal.
Those are the pacemakers of the gut, right?
Yeah.
The specific cells that keep the rhythm of the concrete mixer going.
Precisely. And unlike regular cancers that rely on the lymphatic highways we just discussed, GESTs primarily spread directly through the bloodstream.
Okay.
But the real triumph here is the treatment. GESTs are almost always driven by a specific genetic mutation, the KIT mutation. Scientists developed a targeted molecular drug called imatinib.
How does it work?
It doesn't poison the whole body like traditional chemotherapy. It acts as a heat-seeking missile specifically designed to shut down the c-KIT mutation. It totally revolutionized survival rates.
We went from finding tumors by feeling a left collarbone to deploying heat-seeking molecular missiles.
Science moves fast.
For our final chapter, let's talk about intentionally reshaping the stomach, not to remove a cancer, but the science of bariatrics, using surgery to treat severe obesity and metabolic disease.
The modern bariatric landscape is dominated by two main procedures: You have the sleeve gastrectomy, which is currently the most common, where surgeons staple off and remove a massive portion of the stomach to turn it into a narrow tube.
And the other one.
Then there is the Roux-en-Y gastric bypass. That is the gold standard, where they create a tiny stomach pouch and reroute the intestines to skip the upper digestive tract entirely.
The critical physiological takeaway from the text
Hmm.
completely shifts how we view these surgeries. Most people assume bariatrics works purely through restriction, making the stomach so small you physically can't fit the calories in, or malabsorption so you just don't absorb them. But the guide stresses that bariatric surgery is profoundly hormonal. It's not just plumbing, it is endocrinology.
That is the major modern paradigm shift. When surgeons perform a sleeve gastrectomy, they specifically remove the fundus, the upper dome of the stomach.
Okay.
That specific tissue is the body's primary factory for a hormone called ghrelin.
The hunger hormone. So it's not just putting a physical padlock on the refrigerator door. They're actually going in and cutting the electrical wires to the check engine hunger light in the brain.
That is a perfect analogy. Ghrelin is what makes your stomach growl. It is the chemical signal that tells your brain you are starving.
Right.
By removing the fundus, you drastically drop the ghrelin levels. Simultaneously, the rapid transit of food into the intestines artificially spikes the levels of satiety hormones, like GLP-1, which actively tell the brain, I am completely full.
So you aren't just physically restricted, your brain genuinely loses the desire to eat.
Exactly. But this anatomical hack has a steep physiological cost.
It does.
Oh, yeah.
Yeah.
You are fundamentally altering human digestion. Just like the total gastrectomy patients, bariatric patients face lifelong nutritional deficiencies.
It makes sense.
They require constant monitoring and supplementation for B12, iron, calcium, and thiamine. Furthermore, the massive, rapid weight loss triggers the liver to dump cholesterol, which leads to a really high risk of gallstones.
Ouch.
Yeah, many patients have to take a daily prophylactic medication called ursodeoxycholic acid for 6 months post-surgery just to prevent their gallbladder from failing entirely.
Wow. We have been on an unbelievable journey today. We started with a tiny embryonic tube doing a 90-degree LRT spin. We explored a 1.5-liter, 3-muscle-layered concrete mixer capable of grinding food, getting stressed out by brain swelling, and growing Rapunzel hairballs that can be dissolved by Coca-Cola,
It is a lot.
and dictating our deepest hunger to the brain via ghrelin.
It is a vastly underappreciated organ. If we synthesize everything we have learned from the source material, I want to leave you with a thought to ponder.
Let's hear it.
If a lethal cancer like malt lymphoma can be cured entirely by killing a single spiral bacteria with antibiotics, think about that. And if simply cutting away a piece of the stomach instantly rewires the human brain's hormonal desire to eat,
Right.
how much of our daily mood, our cravings, and our overall physical destiny is being secretly dictated by this strange, muscular, acid-filled pouch that we entirely ignore until it growls?
That is a wild thought to leave on. Maybe trusting your gut feeling is a lot more literal and chemical than we ever really realized. Thank you so much for joining us on this deep dive into the source material. Until next time, keep questioning, keep learning, and maybe chew that pizza just a little bit longer.